and logging in on such a very short notice. Today's topic is quite pertinent. I know in the last couple of weeks or days, the public or the media has been awash with a lot of news regarding this virus that we call the Hantavirus. There's been a lot of anxiety, a lot of fear and uncertainty in the general public. And these fears, of course, do speak to the experiences lived. Most of us, we do remember the COVID pandemic. And in a post-COVID-19 pandemic, definitely news of any viral outbreak will understandably raise such concerns and fears. And like we say in public health, the most dangerous threats are the ones we aren't looking for. So it's very important that as the public, as scientists, we get to know more about this imminent threat and see how best we can respond. So welcome. My name is Winters Mutamba. I'm a research scientist at the Lung Institute, Makerere University, but I'm also the CEO of the Interdisciplinary Consortium for Epidemics Research, or ISA, that is organizing this webinar as part of its mandate to inform pandemic or epidemic preparedness and response. And we think this webinar will definitely get us more prepared should this outbreak emerge within the country. So for today, we'll dive into several aspects of this hantavirus. We'll get quick updates on how the situation looks like. We'll go back to class and understand a bit of the virology. What is this thing called hantavirus? We'll delve into the clinical presentation and management. How do we prevent it? And then we'll hear from the Ministry of Health on what the expectations would be from all of us, even as we get ready for this outbreak. At least what we know for a fact is that there is this outbreak. And what we also know is that up to around 8 countries are actively following up or monitoring the several passengers that were on this so-called ship, which has a very difficult name, but the ship that did start from somewhere in Argentina. And to break all this down for us this morning is a star-studded team of experts. And you'll allow me to introduce them. So we do have Dr. Elizabeth Mugambe Adjambo from the World Health Organization country office, that's Uganda, who joins us to give us the perspective or the situation as it is right now. We're also blessed to have Dr. Misaki Wayengera. Dr. Misaki Wayengera is a senior lecturer at Makerere University. He's the chair of the Scientific Advisory Committee of the Ministry of Health and Epidemics. Dr. Wayengera is also a scientist and a scientist within the Interdisciplinary Consortium for Epidemics Research, where he is the deputy chair of this executive committee or the board of ISA. We're also blessed to have Professor Pauline Vyachika. Professor Vyachika is a professor of medicine. She's the Vice Chancellor of Mbarara University of Science and Technology, or MASTER as we know it. She's a fellow of the Royal College of Physicians and is also a scientist and member of the executive board of ISA. We're also blessed to have Professor Bruce Chirenga. Professor Bruce Chirenga is the chair of the executive board of the Interdisciplinary Consortium for Epidemics Research. He's the principal, Makerere University College of Health Sciences, and is the founder and director of the Makerere University Lung Institute, and also a fellow of the Royal College of Physicians. We also have Dr. Kitula Hagai Sande. Dr. Kitula is the Principal Medical Officer, Public Health Emergency Preparedness and Response Division in the Ministry of Health. So colleagues, that's the lineup. We'll use around 45 minutes or so for the presentations. We'll have back-to-back presentations from the presenters. Thereafter, we will have an opportunity to interface or interact with the presenter through a Q&A session when that time comes. But as the presentations go on, you could still post your questions within the chat so that we can address them when that time comes. So without much ado, allow me call on Dr. Elizabeth Adhiambo to give us the situation updates from the WHO Country Office. Over to you, Dr. Adhiambo. Do we have Dr. Adhiambo on? Super.
Yes. Can you see me?
Very clear.
Okay. So let me share my screen. I hope you can now see my screen. So as has been indicated, I'm Dr. Elizabeth Mugambi. I am the Emergency Preparedness and Response Lead in WHO Uganda. I'm happy to be with you here today. So I'll be taking you through the situation updates with regards to Hantavirus. So I'll give you a little background. This is the background that we have. This was first reported on 2nd May through the IHR, National IHR Focal Point of the United Kingdom of Great Britain and Northern Ireland. So the report was regarding a cluster of severe acute respiratory illness. And this was involving 3 passengers, 2 were dead and 1 was a critically ill passenger. They were in a ship, a Dutch flagged cruise ship, which had started off from Argentina. So on 2nd May, sorry, I don't know, oh, my slides moved. Sorry, I don't know what could be wrong with my slides. Okay, yeah. So on that same day, samples were collected and 1 tested positive for hantavirus. This testing was done in South Africa and results came back and it tested positive. So on 3rd May, again, there was 1 additional death. By the time they were reporting, it was 2 deaths that had been reported. But an extra death was reported on 3rd May. And when it got to 4th May again, the total cases were now 7, which were 2 confirmed and 5 suspected cases. And this included 3 deaths. As you can see, the progression was really progressing quickly. And by 8th May, the cases had reached 8. 8 cases had been reported, and this included 3 deaths, and 6 had been confirmed. So these illnesses, for all these cases that had been reported, that occurred, the symptoms had started between 6th and 28th April, and they were mostly characterized by fever, gastrointestinal symptoms, and there was rapid progression to pneumonia and acute respiratory distress syndrome, as well as shock for most of these patients. So this vessel had departed from Argentina on 1st April, and it was following an itinerary across the South Atlantic and had multiple stops in remote and ecologically diverse regions. And these are the areas that have been listed there where the ship was having the different stops. However, the extent of the passenger's contact with local wildlife during the voyage or prior to boarding remains undetermined. So in total, there were 147 passengers and crew who were on board, and 34 of these passengers and crew had previously disembarked. So as of 4th May, the vessel had to be anchored or parked at the coast of Cabo Verde, and it resumed again the trip on 6th May. That time it left and it was heading to Spain, where disembarkation is planned. So this is the distribution of cases and by outcome status. That is as of 8th May. As we can see, as I said, the total number of cases as of 8th May were 8, and this includes 6 confirmed cases and 2 probable. And of all these, 5 were alive and 3 were dead. So all the 6 confirmed cases had been identified as Hantavirus, which is a species of Hantavirus. And these were the operational case definitions that were being used to identify cases. 1, a suspected case was defined as anyone who shared or visited a conveyance where there has been a confirmed or probable Hantavirus case, and they have acute symptoms, which include fever of 38 and above, myalgia, chills, acute gastrointestinal symptoms like nausea, vomiting, diarrhea, and abdominal pain, or having acute respiratory symptoms like cough, shortness of breath, chest pain, difficulty in breathing. So this is now the case definition that is in use. It was being used to identify additional cases. And even in these countries that are also currently responding to this event, they are using these case definitions. Then the probable case is defined as a person with signs and symptoms of a suspected case, just as I've mentioned in the above definition. And they've been evaluated by a health professional, and they have been found to have a link with a confirmed or probable case, but for which we were not able to conduct lab results. So this is the definition for the probable case. So there is a link. They have symptoms of suspected case, but laboratory tests are not conducted. Then the third criteria is confirmed case. This is a person with lab confirmation of Hantavirus through RT-PCR or serology testing. So this is the epi curve as of 8th, as you can see, but this is based on the date of onset of symptoms. And as you can see, the first case, the symptoms onset were 6th April. And this case died before testing. And that is why it remained as a probable case. Then again, when you look at now the different patterns, as you can see, the red are confirmed cases. And as you can see, there are 6, and it is showing when their date of onset of symptoms were, and also the probable case as well, which you can see the orange, there are 2 in number. Additional information on the situation. So currently there are a total of 4 patients who are hospitalized. 1 is in the intensive care in Johannesburg in South Africa. 2 are in different hospitals in the Netherlands, and 1 is in Switzerland. Contact tracing of the passengers who embarked at St. Helena is ongoing. So the passengers had been contacted and advised to self-monitor for the symptoms, and also passengers who traveled on the same flight from St. Helena to South Africa with one of the cases who was subsequently confirmed have also been contacted. So there are a lot of efforts to continue with contact tracing efforts in these areas where there have been confirmed cases. Further investigations into the potential exposure of the first case, and which is also the source of the outbreak, are also ongoing. And this is being done in collaboration with authorities in Argentina and Chile. And these are the working hypotheses, even as the investigation is ongoing. Based on the currently available information, the working hypothesis is that case 1 most probably acquired the infection prior to boarding through environmental exposure during activities he conducted in Argentina and Chile. So because this first case traveled across through Argentina and Chile for 3 months prior to boarding this ship. So that is the first hypothesis, though investigations are still ongoing. So it is postulated, because when it was reported, they reported the 3 cases at the same time. So current evidence also suggests that the other two cases that happened immediately after this first case could have also happened as a result of interpersonal contact between them. But now the alternative hypothesis that is also being considered, so the most likely is the first one where we've talked about, the first case being the patient who had the client or the patient who had been in Argentina and Chile and boarded from there and then transmitted to these two other people. But the other alternative hypothesis is that all the first three cases could have had a common exposure prior to boarding the ship. So that is the second alternative. So there are ongoing epidemiological and sequencing investigations, and in due course, they'll be able to determine really the source of the outbreak. And that is why this is also being done in collaboration with the authorities in Argentina and Chile, where the first case boarded from. A risk assessment has been conducted by WHO. Normally when there is an outbreak or which is of concern, public health event of international concern, a risk assessment is conducted so that we are able to see what are the risk levels, and this then guides the preparedness, readiness, and response measures for the different countries. So the risk assessment was found to be moderate for the passengers who are remaining in the cruise ship, and it was found to be low globally. And these are some of the factors that were being considered while the risk assessment was being done. First, the hantavirus Andes is serious, but it's usually low incidence public health risk and it's driven mainly by environmental exposure to rodents and their excreta. So it is very serious, but the incidence is usually low from experience. Then based on the current epidemiological information that is available, as I indicated earlier, the likely primary case had exposure in South America and boarded during incubation period. So was already in the incubation period during boarding. Then subsequently confirmed cases, now the two others that followed immediately could have been by interpersonal contact during this infectious period and during the 2 to 3 weeks of exposure that they had together. And the other alternative that was also being considered as this risk assessment is being conducted is that the initial 3 cases may have had a common exposure prior to boarding the ship. There are, however, still many unknowns that investigation is still ongoing, and it will become clearer as more information becomes available. And these investigations also include laboratory analyses that are also going on. Again, when we look at information from previous Andes virus outbreaks, it is found that human-to-human transmission is usually limited. It tends to remain clustered and generally requires prolonged personal contact. So you find that this information is guiding also the rating of the global risk as low. Then again, this Andes virus can be rapidly contained with control measures in place. Then communicable diseases present an elevated risk on cruise ships due to close living quarters, like in the ship, shared indoor environments, prolonged exposure, and frequent interpersonal contact, which facilitates transmission. So further information, as further information is being available, the risk assessment will be reviewed from time to time, depending on information as it becomes available. So what does this risk assessment tell us? I think this is the end. But basically for global risk assessment, as I indicated, it is rated as low. So for countries, what is required is to just continue with the preparedness activities and to ensure that in the event that we were to have a case in Uganda, is the lab able to confirm? Is the surveillance system active enough to be able to quickly detect any suspected cases? Then can the lab confirm? Are we able to isolate the cases that can be found as suspected cases? So it's around just ensuring that we have the infrastructure and the structure ready to handle any eventuality in case we were to report any case. Thank you very much. That is the end of my presentation. I think these are just the short descriptions of the different cases. When I share the slides, you'll be able to see the description of the cases. I didn't want to go through them one by one for the sake of time. Thank you very much.
Thank you so much, Dr. Diambo. It was quite enriching. We actually didn't want you to stop. Of course, some things are quite scary, especially when you mention that there are people who disembarked, and in a world that is increasingly becoming more globalized, you fear, you start thinking, where are these people who disembarked? But thank you so much. We'll quickly dive into the next session. Dr. Wayengela will be telling us a bit more about this virus that we call the hantavirus. What's this big elephant, Dr. Wayengela? Over to you.
Okay, thank you. Winters, I hope you can all hear me loud and clear.
Zara, help me share, or any of that means. Could you kindly share Dr. Wayengela's slides, please? Thank you.
Okay, thank you. As Zahara prepares to share the slides, my role here will be really to talk about the taxonomy. That is the classification of hantavirus, the virology, that is the structure of the virus, the genomic structure, as well as the replication cycle, and how all these interface with the epidemiology, the clinical presentation of the disease. So basically, hantaviruses are single-stranded negative sense RNA viruses that belong to the family Bunyaviridae. And the Bunyaviridae viruses cluster of viruses include about 4 or 5 genera. Thank you. Thank you. Okay, let's go to the next slide. Next one. Yeah, this is the reason why we are here, which the WR has ably mentioned. We are here because of course, that instance on the on that ship. But as we discuss, of course, one of the things we should be looking at is the ecology of hantaviruses in our backyard, the fact that these are transmitted by rodents, and we have several of these rodents within our homes, within our places of work. And it's majorly the contact with the either fecal matter, urine, or even scratches from these rodents. Next slide. Can we move the next slide, please? So like I started, these belong to the Bunyaviridae family, which comprises of enveloped, segmented, single-stranded, negative sense RNA viruses. And the major genera include the orthobunyavirus, the flavivirus, the nirovirus,
Looks like we've lost the presenter. We'll wait for Mizaki to come back.
Isaac, are you there? I feel we might have lost the presenter.
I think he'll
Isaac?
come back shortly.
Okay, yeah, let's just allow him some time, please. In the meantime, please do register your emails in the chat section. This is for us to share the recording with you, but also the slides. So do share your email contacts as we wait for Dr. Wayengera to join. I also do hope you're taking note and probably jotting some questions. Like mentioned, we'll give you an opportunity to engage the presenters in a Q&A session. Dr. Wayengera, are you on now?
Maybe we could prepare Professor Pauline in the meantime if she's around.
Yeah.
Let me try
Yeah.
to look for Mizaki.
Okay. Yeah, so yeah, apologies, colleagues. When Misaki rejoins, we'll definitely allow him complete that presentation. It was actually supposed to introduce us to the other aspects of the presentations this morning, but in the interest of time, do allow me invite Professor Pauline Biachika, the Vice Chancellor, Mbara University of Science and Technology. Over to you, Professor.
Good morning, everyone. I've switched on my video temporarily so that those who do not know me can see me. Then after, I'll switch it off. I'm very glad to be here with you this morning to present on this webinar on Hantavirus. As you all know, many times, especially here in our setting, we don't have the luxury of some diagnostics. So I'm not sure anybody has diagnosed hantavirus disease in Uganda with documented lab diagnosis. But probably it has happened. I don't know. We cannot tell. But we need to be on the alert going forward, having listened to the first presentation. So I'm going to talk about the disease caused by hantavirus. And here, most of the emphasis is on the hantavirus cardiopulmonary syndrome, but we also need to know that it causes the hemorrhagic fever with renal syndrome, although the virus that causes the two is different, and specifically the one that was isolated and the first presenter spoke about was the Andes virus. And perhaps most of the presentation might concentrate on that one. So looking at the pathogenesis of the disease and the pathway of the disease, unfortunately, we haven't listened to Misaki's presentation because it was going to lead us direct into this presentation, but maybe we shall catch up. So we know that this disease is rare, but when it occurs, it can be severe and fatal. And as we heard from the first presenter, it's been isolated and traced to South America, the Americas. However, the other species have also been located in Europe. And before 1993, it was exclusively known to cause the hemorrhagic fever with Raynaud syndrome. But after that, the cardiopulmonary syndrome emerged, and this caused a paradigm shift in this virology and infectious disease care and knowledge. So this virus, as we heard from the first presenter, is rodent-borne and transmitted through inhalation of aerosolized virus from rodent excreta. So the exposure is through inhalation of rodent excreta aerosols, which leads to infection of either the pulmonary or the renal endothelium. We're told it has a special attraction in layman's language, predilection for the endothelium in the pulmonary vasculature and causes severe disease in the pulmonary vasculature in form of cardiopulmonary syndrome. It has a mortality rate of about 30 to 40%, but we are yet to hear from WHO who are going to follow up the individuals exposed in this particular one. So this cardiopulmonary syndrome was first recognized in the 90s, and following this was recognized following an outbreak of an acute but highly fatal non-cardiogenic pulmonary edema, and that was in the USA. And the hallmark of its disease is really the cytokine storm. So I may not read word by word of what is on the slide, but just to let you know that the hallmark is the cytokine storm. We have seen many diseases that lead to this cytokine storm. And the worry, of course, is the recent pandemic of COVID-19, which caused a massive cytokine storm. So this hantavirus cardiopulmonary syndrome is characterized by infection of the endothelial cells. So the endothelial cells are initially infected, and this leads to dysregulated cytokine reaction with increased capillary permeability and pulmonary edema, leading to cardiogenic shock. So if you look at the pathophysiology in detail, the virus triggers off this hyper-inflammatory state, which is characterized by the cytokine storm. And these cytokines profoundly disrupt the pulmonary microvasculature barrier function. So they cause increased permeability of the microvasculature, and therefore leakage or extravasation of fluid from the intravascular space to the extravascular space, thus causing pulmonary edema. As I said, it selectively infects the hantavirus, the Andes virus in particular, selectively infects the pulmonary microvasculature, endothelial cells, and that activates that local innate and subsequently adaptive immune responses, including recruitment of specific CD8 T cells and mononuclear effectors, as you can see on the slide. I think I don't have to go through the detail of the cytokine storm. And this leads to systemic shock. So the pathogenesis is driven by the host immune dysregulation rather than direct viral cell disruption. And that host immune dysregulation is what causes the massive leakage of fluid because of increased permeability, causing edema and causing respiratory failure and acute respiratory distress syndrome. Next slide. Oh, am I the one changing the slides? Oh, yes. Okay, so I have described the pathophysiology, and I hope when Misaki comes on board, he will speak a little more in detail about some of the things that I may have left out. So the disease itself, the mechanism of disease, as I mentioned, comes from that increased permeability that leads to pulmonary edema. And of course, when there's pulmonary edema, there's poor oxygen exchange, and there's also shock. So in the early days, the prodrome, the first about 3 to 6 days, the prodrome phase of the disease, patients will have non-specific symptoms, including fever, including muscle aches, which we call myalgia. They will have fatigue, they may have a headache, and that is really non-specific, and you may not really suspect. So maybe the message here is that since we are getting more and more of these viruses on board, we always need to be on high alert and always practice infection control measures in especially our hospital settings. But even in the social, in the public, it's important that we always follow infection prevention and control measures, because you can never know. For example, these ones were enjoying the cruise and they didn't know that somebody had been exposed. So following the prodromal period, this progresses rapidly to either the cardiopulmonary syndrome, if it is the Andes virus, or it may progress to the hemorrhagic fever with renal syndrome. And in this case, we are concentrating on the cardiopulmonary syndrome, which in my opinion is the more fatal disease, because anything that affects your lungs usually will kill you very fast. So here you get progressing into the cardiopulmonary syndrome, patients will present with cough, dyspnea, and hypoxia. And you can see these are all symptoms of reduced oxygen perfusion, and also symptoms of presence of fluid in the pulmonary interstitial spaces that are causing dyspnea due to pulmonary edema, and hypoxia also due to reduced oxygen perfusion. And usually a patient with these symptoms requires immediate care in the ICU, because without that immediate care in the ICU, patients will deteriorate very fast into the critical stage where they have massive pulmonary edema and they go into shock. So there's rapid progression to this critical stage if not cared for, and preferably should be cared for in the ICU setting. I know that some of our ICU settings may not necessarily provide state-of-the-art care, but it's important that we admit patients in the ICU so that they can get that kind of care. In other centers, rapid initiation of extracorporeal membrane oxygenation, which is also abbreviated as ECMO, is very handy before patients go into complete hemodynamic collapse. So following that critical stage, if patients survive, prognosis, the long-term prognosis carries substantial convalescent morbidity. So the recovery may be prolonged, and patients may suffer prolonged morbidity during the convalescent stage, with exertional fatigue and dyspnea, like we saw during the COVID. Patients who survived COVID, some of them had this prolonged morbidity because of the effect on the pulmonary anatomy. So they have prolonged exertional fatigue. They may have residual functional respiratory limitations, and overall the quality of life will be quite reduced. So this is exactly what I've been talking about. So maybe I don't need to go through this slide again. Yeah, so the key features in terms of clinical features and diagnosis, key features are high fever, respiratory distress because of the pathophysiology that I've just explained, rapid progression of disease, and patients may have other systemic symptoms, including GIT symptoms. In terms of diagnostics, really, as we know, history, physical examination, and laboratory diagnosis should always be the standard. So it's important to check history and find out history of exposure to rodents or rodent excreta. It may not be clear-cut, but find out some kind of history to be able to start getting some kind of suspicion. It's also based on the clinical syndrome, and of course, where there's been exposure to patients like these ones on the cruise, it will be quite very obvious. In terms of diagnostics, you may perform serology early on with the IgM antibody tests and later on with the IgG antibody testing. PCR will give you a definite diagnosis for hantavirus RNA. And clinically, a chest X-ray is quite useful, and it will show you pulmonary edema with interstitial pneumonia. The differentials include pneumonia from influenza virus. COVID-19 can cause a similar picture, mycoplasma pneumonia, severe community-acquired pneumonia, and other hemorrhagic fevers. So the case definition, I know the first presenter gave us a case definition for purposes of surveillance that they are doing. And here we'll say case definition will include an acute febrile respiratory illness, unexplained cardiopulmonary compromise, history of travel or exposure risk within the previous 6 weeks, and healthcare or household contact with a confirmed case like we are seeing from the cruise. Management, the clinical management, to date, there is no specific antiviral therapy, and most of the management is supportive care, like we know for most of the viral diseases. Usually it is supportive care. Early ICU care is very, very important. Ventilation support is very important. And of course, infection prevention and control measures must be a standard while caring for these patients. I'll stop there because the rest of the prevention is going to be covered by Professor Chirenga. Thank you very much for listening to me, and I will entertain questions at the end. Thank you.
Wow. Thank you so much, Professor Byachika, for walking us through how would manage a patient with this hantavirus. Again, like we mentioned, Q&A at the end. We have had Misaki, Dr. Wayengela rejoin. I hope that he can run through the remainder of his slides. Let me see. Do we have you, Dr. Wayengela?
Yes, Winters, finally I'm on. Sorry, the whole thing is oversubscribed, and I'm using a mobile gadget. Somebody called and kicked me out. It was difficult to get back.
Sorry about that. So we'll screen your slides again. Carol, Prof. Byachika, you might want to stop sharing. Let's have Carol. Could you screen share Dr. Wayengela's slides? I think they are coming up.
Okay, thank you. And I saw some messages, people saying they were not able to hear me, but I hope everybody can hear me now. My role here is to talk about the taxonomy and the virology, including the structure of the hantavirus, the replication cycle, and how this interfaces with the clinical presentation and the epidemiology of hantaviruses. And previously said, the hantaviruses belong to the family Bunyaviridae, which comprises of enveloped, segmented, single-stranded RNA viruses, which are negative cells. And within the family, we have 5 genera, which include the orthobunya viruses, the flaboviruses, the niroviruses, and the orthohantaviruses. And I said that within this classification and within some of the other genera is where we find Rift Valley fever, as well as Crimean Congo, which happen more frequently in our setting. Next slide. So briefly, these are negative sense single-stranded RNA viruses that are segmented. So in that cluster, you see the group up, which is non-segmented, but the lower group, where the family Bunyaviridae belongs, have segmented RNA. And we have the 5 genera that are linked with this family also listed there. Next slide. So like I said, Rift Valley fever, which happens more frequently, and I know some of our colleagues here are heavily studying the prevalence and incidence of Rift Valley in Uganda, as well as Crimean Congo hemorrhagic fever, belong to the Phlebivirus genera and the Nairovirus genera, respectively. But within the Hantavirus genera, we have a cluster of 2 types of hantaviruses. We classify the strains or the species in 2 groups, those which we consider to be from the old world and those that belong to the new world. And I will talk about this in the next slide. So briefly, the Hantavirus genera comprises of over 50 species. These infect rodents and small mammals, each of which has its own reservoir. So every small mammal species carries a specific hantavirus species, but they cause disease in humans and not the rodents that carry them. And like I'd mentioned, the classification is into the old and the new world hantaviruses, which respectively cause either hemorrhagic fever with Raynaud syndrome or hemorrhagic pulmonary syndrome, which we are now experiencing with this Andes virus. Next slide. So briefly, you can see the different mammals. Of course, you have some that do not necessarily affect us humans, but affect other species. But our focus will remain on those that affect us as humans. Next slide. So within the old family, the first 5 species, Hantavirus, which is found in Asia, the Pumala virus, common in Europe, as well as the Sol virus and the Debra Belgrade virus, linked with the old world. And I will try to demonstrate what is meant by the old world. Then the Sain Nombre virus, the Andes, the Boye virus, and the New York virus belong to the New World. Next slide. Next slide shows us a map of the world, which essentially outlines what is considered to be the old world. And you can see the species distribution there. And from the current outbreak, we are experiencing the Andes virus and Andes virus species, which is probably named because it's linked to the Andes Mountains in Brazil, in South America. Next slide. So the overall structure, these are spheres, but they could also assume a pleomorphic, and by pleomorphic it means they take on shapes that are unpredictable. They contain a 3-segmented RNA virus, which is segmented into the large, the medium, and the small segments. This, I must note, also allows for reassortment or genetic shifts, subsequently leading to new strains that might not necessarily present in a similar way like the previous strains. Next slide. So these are, in terms of the virions are enveloped, they are spiked, they are majorly spherical, they are about 80 to 160 nanometers in diameter. They comprise a lipid envelope that is covered in spike proteins made of two viral glycoproteins, the GN and the GC. The GN essentially forms the stalk, while the GC is the head that is exposed outside. Next slide. In terms of the genomic structure, the hantavirus specifically is 12.1 kb. And of course, like we had said before, the RNA is segmented into three. The large, which codes for the RNA-dependent RNA polymerase, and the medium, which encodes the glycoprotein precursor, and the small segment that encodes the nucleocapsid. Next slide. Next slide, please. Move the slides. In terms of this genomic structure, there are some few unique things that we need to pay attention to. Go backwards to the previous slide. The fact that each of these segments, could we go to the previous slide, please? Each of these segments is flanked by untranscribed RNA that forms the caps, and these caps enable the RNA to wind around itself in a manner that creates what they call a panhandle structure. And that is something that we need to pay attention to. And in the next picture, I was actually trying to demonstrate what is meant by the panhandle structure. Next slide. So you can see that this is the structure of the handle for the pan, and you can see how this RNA is arranged, winding around itself, but also, of course, being interlinked with the ribonucleoproteins. Next slide. So in terms of the replication, this picture shows us the replication cycle of the hantavirus, majorly attaching onto integrins, particularly those of the beta type, and entering through fusion. Subsequently, of course, the coat, the outer coat, is absorbed either by lysosomes or it is taken up by endosomes, releasing the RNA. The RNA is subsequently transcribed, but also replicated. And the transcription for the hantavirus happens in around the reticuloendothelial reticulum of the Golgi apparatus. And the assembly and egress takes the pattern of picking up the RNA that has been reassembled into the different segments and packaging them into into the structures that we saw, the panhandle shapes, and subsequently, as the virus egresses, it picks up part of the cellular membrane to form its envelope. Next slide. So this is partly what I'm talking about. The entry is mediated using the beta integrins, and these viruses are tropic majorly for epithelial cells and macrophages. And as Professor Pauline mentioned, the pathology is majorly mediated by epithelial leakage happening because of the inflammation in the epithelium, but it's also mediated by cytokines that are released from the macrophages, particularly the tumor necrotic factor alpha as well as nitric oxide. These subsequently lead to fluid leakage that leads to edema and, of course, hemorrhage. Once the virus has attached, it fuses and enters into the cell through an endosome. Endosomes. pH plays some substantial role, and there you have the translation and other things. In terms of the transmission, these are zoonoses, but there is ability to establish human-to-human transmission. Next slide. So these viruses, like we mentioned, the hantaviruses are specifically unique in that they are arthropod-borne, and each species has its own mammalian rodent host. And the hantavirus rodent host is the long-tailed pygmy runt from the Andes mountains. And of course, transmission happens through urine, feces, exposure to urine, feces, saliva, bites, as aerosols, which are inhaled. And we've seen instances where there is established human-to-human transmission. Next slide. So here is the picture that we probably need to pay attention to in terms of the public health interest. The fact that a lot of the transmission happens by inhalation of the aerosolized particles. And we also know that within our setting, we have all these rats, and I would be interested that some of our epidemiologists, virologists here, and immunologists try to consider what is the seroprevalence of hantavirus in the context of our setting, given the fact that our people live with many of these small mammals within their homes. Direct contact follows a protracted exposure, but it can also happen when any of these animals attacks you. And we've seen, of course, the WR mentioned that it requires substantial exposure for human-to-human transmission to happen. Next slide. So this is my last slide, and the key thing here is to mention that one of the doctor, or actually on the cruise ship, was actually got exposed and is one of the patients. So in part of the epidemiology for us as clinicians, perhaps the key thing to be looking at is as we plan, or if any of this happens, we probably need to take precautions that protect against the aerosolized particles. Thank you.
Thank you, Dr. Wayengela, for breaking this down for all of us. Virology is quite a difficult topic, but you did make it easier for us to understand. Of course, you left us with some bit of fears. We are all surrounded by rats, and it should worry us a bit on whether these rats actually are carrying the virus. So colleagues, we'll dive into the next session on prevention, and this will be led by Professor Bruce Chirenga. Over to you, Professor.
Okay. Oh, my video can't come on. Okay, I think it has come. Let me see. Probably you can go to the first slide, but my video is not showing. Are you able to see me?
It's probably covered. The icon just popped up. Yeah, I don't know, but we can't see you.
I don't know what is covering it. But anyway, people don't know me. I am Bruce Chirenga. I will actually switch it off so it doesn't disturb me. So go back to the first slide, please. The first slide. As we bring the first slide, and please put them in presentation mode. Thank you, Mizaki, and everyone for joining the meeting. Mizaki, actually, you showed a very scary thing. There is that round thing you showed. I saw very many animals there, including a picture of a fish, which carries, is it the actinovirus? And that really is scary. But winters, many of our people no longer live with rats. We are now a middle-income country. So let me start on what I'm supposed to do. My first slide has not come, but me, I have a simple job, is to really talk about the prevention as it is known now. And I will mainly talk about, I can actually show my slides because I have them here. Yeah, I have them here. Okay, you can see them now.
They're coming up. Yeah,
Yeah.
they're on now.
So oh, Kayaji is also screening. Kayaji, can you stop?
Yeah, it's okay now. So, Prof, you can now screen.
Oh, sorry, we are losing some minutes here. Okay, is it fine?
They're coming up. They are on now.
Okay, so I was saying that now we need to synthesize the science that Mizaki has gone through to see how we can prevent this virus. I will mainly talk about the public health interventions to prevent the virus. But I know people will want to ask me about vaccines. So I have one or two vaccines things to talk about. I will first say is that this virus, as we speak now, we don't have established medical or biomedical prevention measures, including vaccines. So therefore, the important thing are the public health interventions to prevent it. The first one, as you've heard, this is mainly a virus that jumps from animals to humans. And the good news is that for most of them, human-to-human transmission is not possible. But for this Andes virus that we are talking about, there is a possibility for human-to-human transmission, as was mentioned in the first presentation. So the first thing is environmental control, that we needed to implement measures to prevent really interaction of humans with those rodents. But like I mentioned from Mizaki's slide, I don't know whether people saw it, there are quite a number of these animals that you may not know which one you got exposed to. And as you heard from Elizabeth's presentation, the first hypothesis that people actually got exposed before they got onto the ship. But of course, we know what happens in the basement of those ship. Probably there were some rodents that people were exposed there. So one of the first things is that to make sure that there are no exposures to these animals. The second one, this sounds like common sense, is sanitation. Even when there are these animals, they live in the environment where you are, you need to make sure that there's strict sanitation to avoid these droppings accumulating so that you get exposed. The other one is to create awareness, and that's one reason ISA has taken on this exercise, although we know there are no cases in Uganda, but create awareness. And like Mizaki said, and previous presenters and other people online, some of these pathogens are actually in our environment. You've heard of the Bunya viridi. I think someone posted that actually this was found in a certain village in Uganda called Bunyawera. So these things are with us, So now that there is an outbreak, we need to create awareness, and that's why we made this webinar a public. Now, once you have established cases, then we need personal protection, PPE. PPE will become very popular during COVID-19, and I won't spend so much time explaining this, is that if you are looking after these people, confirmed, probable, and possible, and contacts, you need to have personal protection equipment. Now, like I've told some of my colleagues, when something has entered the respiratory system, I don't trust it that it will not be transmitted. So we need to make sure that we are alert, because this is an aerosolized infection, and therefore, once it is in the air, it can gain quick access. So when we have looked at the theory, now we go to the public health strategies. These are the strategies people in the Ministry of Health, in WHO, and other public health agencies can implement immediately. Yes. For example, the first one is notification. Notification followed, so meaning that we all have a duty. Once you have detected a case which looks like a hantavirus or any other disease of public health importance, that you should immediately report this case, probably within the first 24 hours at national level, and at local level within hours. Then that is one strategy. So this means that the people who control, who have the resources to control the outbreak, will have the information. So that is notification. The other one that we do is contact tracing. So once you have a case, you must be able to look for the contacts. And as you've heard, most of the contacts have been identified, and they are isolating in different countries. Of course, there's a lot of debate, especially on social media. People are saying, why did you allow this ship to move and it continue going and docking? You should have left these 150 people on the ship. But of course, those are really inhuman ways. Nowadays, we have enough technology. Even if you have been exposed, we can look after you and will remain uninfected. I think some of us are living example, having treated hundreds of COVID patients, and we remained alive. So I did not support the idea that these people should be left on the ship. After all, you don't know where they came from. Maybe there are even more cases where they came from, but that's a debate you can engage in. Then exposure history. Then we have, these ones I've already talked about: rodent control, hygiene, safe cleaning, PPE, and then community awareness. Now, there's something here I've called prevention of PALS. In any outbreak, yes, there are these things which are key. They should be on your fingertips. Here I'm speaking to the public health control people in the Ministry of Health and others. You must have a high index of suspicion. People working in airports, people working in hotels, people dealing with the travelers. We know there's nothing in Uganda, yes, and East Africa, yes, but we need a high index of suspicion. Now that this outbreak is there, people at the entry points must be able not trust nothing, but of course, not stigmatize people. Then, once you have a high index of suspicion, you will be able to do early recognition, you can prepare, and then care. This one we've mentioned, the role of vaccines. Like I've told you in the beginning, I put this slide here, not that they are vaccines, because I know you are going to ask me, are there vaccines? At the moment, there is no FDA, EMA approved hantavirus vaccine. Please note those words. FDA is the NDA, or the Drug Control Authority of America, and EMA is the Drug Control of the Europeans. According to those two agencies, there is no effective vaccine. But as we'll see in the next couple of slides, there are some things somewhere, as I will show you. Now, the role of a vaccine, once this is now a theory, basic vaccinology, that you should be able to protect, prevent, and preserve. That you need to create, a vaccine should be able to create a shield around vulnerable people. I hope I can slow down such that people understand that this is actually the basic of vaccinology. We vaccinate to protect a single individual, to protect the community, and to preserve the long-term health of the people. So we need a vaccine that will not only prevent individuals from getting infected, but they can create a ring of protection around the community and preserve long-term health. So there are a couple of platforms that people are looking at. These ones I will not bother you so much. I know if I don't talk about this, people will ask me. We have our traditional vaccines, inactivated DNA, particle, but there are also now efforts for Hunter using the messenger RNA technology that became very popular during COVID-19. But I will go here. If you remember, I told you the big boys, the Americans and Europeans have no vaccine that they have approved. But there are some things somewhere. For example, in Korea, they have this thing called Hantavirus, that has shown efficacy of about 57% and is believed to be safe. Now, this thing here, of course, you heard from Professor Pauline, mortality once infected reaches 40%. If you remember, severe disease in COVID was only under 10%. So this is 40%, but of course less transmissible. So these Koreans have something that is up to 57% effective, but is not widely used. Yes. They also have something, the bivalent, as you can see, that has also undergone phase 1, phase 2 studies, and it protects, but the undercutting with it, this HTNV, the protection is only 6 months. But some people, they have something, but it's not globally available. I will leave this and I will go to this. And this is to the immunologist on the call. As clinicians and public health practitioners, we are longing for a time when we will have a broadly active vaccine. Yes, we know these vaccines work through inducing antibodies in many cases, of course, plus cellular component. But our wish from the public health and the clinic is that you can give us a broadly acting vaccine. For example, these, what you called them, their family is called what, Mizaki? The bigger family? Also, no. They are, you said they are Bunya something. All this group, I saw actually somewhere where they branch, actually the viruses are in the same group. Can we have at least a first-line vaccine which can broadly protect? This could be the wish. Otherwise, as you can see now, people have run back to the lab. They are creating a Hunter vaccine. Before they come out, there will be another one and another one, and therefore remain on tenterhooks. And that brings me to the concluding remark that the public health interventions are the biggest ally that we have in these outbreaks, and they saved us from COVID-19, as we saw. Chair, I stop here.
Thank you, Prof. Chirenga, for telling us how to prevent this hantavirus. And I liked also the bit about the vaccines, the presence or absence of these vaccines, which further underscores, I think, the role ISA would ideally play in making sure these vaccines are ultimately, now we can see you, but now we can't hear you, but we see you, Prof. Chirenga. So ISA definitely is supposed to fill some of these critical gaps around how safe these vaccines are, how effective they are. And it's good that there are some vaccines in the pipeline. So hopefully they ultimately get here and we provide the needed evidence that would support their rollout. So colleagues, we'll go into the last presentation. And this is a presentation from Dr. Hagai Sunday from the Ministry of Health. And I hope by the time he's done, we should be able to know whether we should fear as a country in terms of how ready we are to hit this outbreak if it does happen? Over to you, Dr. Agai.
Thank you so much. Can you allow me to share from this side? Thank you so much. I want to believe you're able to see my slides from that side.
Yes, we can. If you can pull them in a presenter mode. Great. That's fine now.
Thank you, colleagues, and thank you for everyone for the wonderful presentation you have made ahead of me. I know you have somehow you summarized my work, but I want to say that as a country, we are in a alert state, alert mode of this virus. It means that we have now heightened our surveillance. So this is this presentation really is going to be twofold, giving information, but also to call upon the regional emergency operation centers to go into the readiness state and into the alert mode because of our points of entry that are in some of these regions. So allow me to skip the agenda. But why is Uganda? Why are we interested as Uganda? Why must we get concerned? Chair will allow me to show my face when I'm almost done. But let us know why Uganda we must act now. Number one is that Uganda, we have a lot of rodents around us, as you know. Common in our agricultural zones, which is mostly Uganda. We are agricultural country. We have forests around us, and also these rodents, they have the hantavirus strains most of the time. Then also the connectivity, the travel connectivity, Entebbe Airport from South Africa, from Europe, Middle East, all these regions that have had the confirmed MV hideous contacts, really, they have a propensity of reaching in Uganda. Then also our limited capacity, ICU capacity, as you know that most of these, as we've said, they affect the respiratory system. It means that the ICU is the most needed structure that in our health system, because once people are affected, they will need ICU capacity. However, also we have IHR obligations that Uganda is legally obligated to maintain core capacities to detect, do assessment, and also notify and respond at the same time. But we rely on our experience from the Ebola, Marburg. Our infrastructure, we have trained so many people, we have trained health workers on high consequence pathogens. So we're really confident that once we're able to detect at the points of entry or within the country, we have the capability to manage. But also we have to be cognizant of our connectivity with South African borders. Tanzania has access to the sea. Kenya, we can have them come from South Africa to Rwanda, DRC. All that connectivity with porous borders really puts Uganda at a very vulnerable state. I'll look at surveillance and early warning signs, Chair, based on what WHO had already presented, looking at the suspected case, looking at acute febrile illnesses, plus any of the malaria, headache, GI symptoms. Those can be some of the suspects that you may have if you're seeing them in your facilities. So, but all the suspected, probable, and confirmed cases here shall be refined as we get more information. However, we say that we need to be reporting. Clinicians who are able to suspect, please report immediately, report the district health officer, who report to the Ministry of Health Surveillance. Also, we shall report as our mandate to IHR, as our mandate of International Health Regulation to WHO, which we shall also report to WHO where required to the headquarters. Chair, as I told you that we have the point of entry as Uganda, and our biggest point of entry is the international airport, Entebbe International Airport. What makes it a high risk, high priority? Because it has direct connections to South Africa, UK, Netherlands, and Switzerland, where we have had some of these cases. We have had also Malaba border, which is medium, Busia, Mutukula. The Katuna border in Rwanda is really low medium, Chair. So really we our biggest worry is at Entebbe International Airport. The biggest advantage at International Airport, we have some scanners. They're able to, because fever being one of the prodromal that present these patients, we have some scanners which can pick high elevated temperatures in people who are entering the country. So we think that that can be our first area of surveillance to be able to pick some of those people within the country. Laboratory, we have laboratory capacity chair. Professor Bechka said she was worried that we have never organized, but I think the UVRI at Entebbe has capacity to really detect, because we remember that when we had anthrax outbreak in Chotera, with the first suspect that was Hantavirus, and most of we failed to get cases of anthrax from all the tests initially, but we were testing whether it was Hunter, because some people presented similarly. However, it turned out negative for Hunter, so that's why I say as a country have capacity. If really it is Hunter, we shall be able to detect. But also we have the WHO lab in South Africa is also at our disposal. We have also CPHL here, and also we have other labs that really we can bench up to. But also we have developed capacity in terms of collecting the samples, even using full PPEs. We have also capacity of the double bag with the leak-proof containers, and also the carriers are available to transport these samples all over the world. Looking at case management chair, we have designated facilities. We have Mulago. Mulago also, it has an isolation center for viral hemorrhagic fevers where we are managing our Ebola. It's available to us. Mbarara Hospital has an isolation center there. Guru, there is one. Mbale, there is one. But also key rules to the clinical side is that fluid must be cautiously given. Early intubation, vasopressors in case of septic shock that has been reported, but also extracorporeal considerations may be considered in cases of these areas. Chair. Risk communication. Chair, risk communication and community engagement. To the general public, Chair, we say that Uganda, we have very low risk, and also we want to tell the public to avoid rodent contacts. But also where the rodents have become a problem to your area, please contact us on 0800 1066. Also, you can SMS us on 6767, or you can send a direct email on alerts@health.go.ug. If you have people who are returning from outside the country, in those countries that we have talked about earlier on, please don't fear to report, just report and we shall do the rest. Our health workers know the case definitions, report immediately. In case you have anyone suspecting that may be suspicious of the disease, please put on full PPEs and follow the IPC protocols. For the returnees from South Africa, Atlanta in the past 8 weeks and have fever, breathing difficulties, isolate and also call immediately. So our VHTs, please, people from the regions and the districts, educate on rodent control, seal foods, do wet clean only, report illness clusters to the DHO for immediate intervention. We request everyone that please do not give information to the media unless it has been cleared by the Director General. Why we emphasize this? Most of these outbreaks have impact on the economy and also tourism. So if you're not sure of the information, please, we request that everyone should first have clearance from the Director General or the highest office in that region to be clear to speak on it. So, Chair, our legal basis which we act through is the Public Health Act. We may have to quarantine some people without first getting their consent and even isolate them based on the Public Health Act of CAP 281, but also international health regulations demands that we notify. It gives us this obligation as a state party, but also have the National Epidemic Preparedness and Response Policy, where we may have to activate the Emergency Operations Center within the regions so that they take control and have capacity to manage and coordinate and communicate on behalf of the central government. We have the Uganda VHF treatment and IPC guidelines, which have been adopted for 2022 for high consequence pathogens management. And also, Chair, you know that we have the East African cross-border disease surveillance protocol with Kenya, Tanzania, Rwanda, Burundi, South Sudan, and DRC. And also, we are a member of other international agencies like IGAD, East African Community, EXA, which also have the mandates to see that cross-border surveillance is heightened and we're able to overcome or detect early and respond to these public health emergencies, Chair. Otherwise, Uganda will remain to say that our surveillance and early warning systems are up, points of entry, we have capacity, laboratory, case management, and its communication. And for anything that has been detected in the community, please call our emergency hotline on 0800 1066. Thank you so much, Chair.
Thank you very, very much, Dr. Hagai. It's
Good evening. Welcome to
actually
UMA
quite
TV News. I'm
reassuring,
your host, and we
to
have the
know
latest
that,
updates on the top
Uganda is
stories.
ready. For
Top
most
story
of us
tonight.
who are
Health
involved in
officials
the
are issuing an
COVID-19
urgent alert following a confirmed outbreak of the
research
Hantavirus in the
response.
region. The public is urged to
Would,
take
say
immediate
we're actually
precautions to
caught
prevent further
unaware.
spread.
This rare but
But looks
serious
like we are
respiratory
ready now,
disease is
and that's
causing
quite
concern as
reassuring. So
hospital
colleagues,
admissions rise.
we've
Authorities are
come
now
to
tracking
another
multiple
session I
clusters of the
normally
infection.
admire.
Experts
Session
remind the
where
public
we'll
that
engage
hantavirus is
the
primarily spread by
speakers.
rodents.
I know we don't
Humans
have
become
much
infected
time,
through
but we
contact with
could probably
infected
squeeze
urine,
in a few
droppings,
minutes
or
to
saliva.
have this Q&A.
Crucially, the virus can become airborne
We'll
when
ask you
dust
to
is
raise
stirred
your
up in
hand, and
infested
then we'll
areas.
allow you
Breathing in
air
these
out your
contaminated
question to the
particles is
speakers.
the most common
I know
route.
there are so many that have been
Crucially,
put on
the
the
virus
chat.
can
Might be
become
hard for me
airborne when dust is stirred up in
to
infested
get
areas.
everything.
Breathing
The
in
stats
these
are quite
contaminated
long,
particles is the
but
most common route.
I think I will
Experts
read
remind the
one
public
that
that
has interested
hantavirus
me.
is
But before I
primarily
come
spread
to
by
that,
rodents.
I will also use
Humans
my
become
privilege as a
infected
chair
through
to ask
contact
one
with infected
question
urine, droppings,
to
or
Dr.
saliva.
Wayengela.
Good evening. Welcome to
So
UMA TV
one
News.
thing I
I'm
know
your
is we
host,
had
and we have the latest updates on the
hantavirus
top stories.
Top story
outbreaks here
tonight.
and
Health
there that
officials
were
are
isolated
issuing
for
an
quite some
urgent alert
time.
following a confirmed outbreak of the
And again,
hantavirus
picking
in the
from
region. The public is
COVID-19, we
urged to
had
take immediate precautions
things
to
like
prevent further spread.
mutations,
This rare but
variants.
serious
Most of
respiratory
us
disease is
remember the
causing
Omicron and
concern
all
as
those.
hospital admissions
And I'm
rise.
wondering
Authorities
if
are now
such has
tracking
been
multiple
reported
clusters of the
about
infection.
this hantavirus,
Experts remind the public
especially
that
for a
hantavirus
virus
is
that
primarily
has
spread by rodents.
had
Humans become
several
infected through
isolated
contact with
outbreaks
infected
in
urine,
several parts of
droppings,
this
or
world.
saliva.
Is there a
Crucially,
possibility
the
that this
virus can
could
become airborne when
have
dust
actually
is
mutated?
stirred
But
up in
while you
infested
get ready to
areas.
respond, Dr.
Breathing
Wayengela,
in
I
these
want
contaminated particles is the
to read
most
one
common
question
route.
from the chat. This
Crucially,
is, I
the
think, from
virus can
Serena
become
Gole.
airborne when dust is stirred up in
I will
infested
address this to you,
areas.
Professor Chirenga.
Breathing
So the
in these
question
contaminated
is, the
particles
first case
is
is
the most
believed to have
common
been
route.
exposed
Experts remind the
before
public
boarding,
that hantavirus is
and it is
primarily
assumed
spread
that
by
the symptoms
rodents.
became evident
Humans
a
become
bit
infected
later
through
while
contact
on
with
the ship.
infected urine,
How
droppings,
then
or
is it
saliva.
that the people
Good
who are in
evening.
contact
Welcome
with
to
them
UMA
in
TV
the
News.
ship
I'm your host, and we have the latest
drop
updates on the top
symptoms
stories.
immediately?
Top
Does
story
that
tonight.
mean
Health officials are issuing an urgent
transmission
alert
is
following a
more
confirmed outbreak of the
virulent
hantavirus
than
in
the
the region. The
environmental exposure? I like this question because I know
spread.
This rare
you've
but
introduced
serious
some of
respiratory
us to the
disease is
idea of
causing
inoculum
concern
and
as
stuff like
hospital
that.
admissions
So
rise.
that's the concept of
Authorities are
inoculum
now
play a
tracking
role here.
multiple
It is something
clusters of
else.
the
So
infection.
you, Misaki, first,
Experts
and then
remind the
Professor
public that
Chirenga for the
hantavirus
second
is
question.
primarily spread by rodents.
Okay,
Humans become
Winters, thank
infected
you
through
for
contact with
asking the
infected
question.
urine, droppings, or saliva.
And
Crucially, the virus can become
for
airborne
my
when dust is
presentation,
stirred up in
I
infested
actually showed
areas.
that
Breathing in these
these,
contaminated particles is
first
the
of
most
all,
common
RNA
route.
viruses. We
Crucially,
know that
the virus
RNA
can become
viruses
airborne
are
when dust
extremely
is stirred up in infested areas.
promiscuous
Breathing in these
because the
contaminated particles
RNA
is the most
polymerases
common
don't
route.
have the ability
Experts
to
remind the
proofread
public that hantavirus is primarily
whatever mutations come through. They cannot eliminate mutations when they happen. So that alone makes these viruses prone to have a change. But also the segmented structure of the RNA makes it very easy and possible to have reassortments, which can lead to drifts, eventually leading into new strains emerging. Now, I don't know Winters, but there are some sets of questions which are interesting on the call, on the chat. I don't know whether I should go ahead and respond once so that I move off, since you are the chair.
Yeah, you can quickly run through them. I see 3 hands up.
So
once you're
somebody
done,
asked about the history of the Bunya viruses in Africa. They, like Prof indicated, the word Bunya viride actually emerges from the name of the Bunyamwera virus, which was discovered in 1943 in Uganda. And that Bunyamwera virus was discovered in Semiriki forest. It is transmitted from the Aedes mosquito. It belongs to the genera Bunya virus, where the lacrosse virus also belongs. Another person asked, how does the Hantavirus disease relate to good pastures disease? Hantavirus disease is majorly mediated through capillary leakage, while good pastures is majorly antibody mediated. But of course, there is data to show that because of the inflammation that happens to the glomerular basement membrane, there is production of antibodies that could potentially cross-react with the good pastures test, which tests for antiglomerular basement membrane antibodies. So perhaps that is the relationship. But the clinical presentation is very similar. And almost everything from the hemorrhagic fever, renal syndrome, to the hemorrhagic pulmonary syndrome and ARDS can happen in either the two. Someone asks what type of rats exactly. The rat indicated as a reservoir for the Aedes hantavirus is the long-tailed pygmy rat. But of course, it would be of interest to really study some of our rats and see what do they carry. Another person, of course, had asked whether dogs could be potential intermediary hosts. And also this emphasizes why we need to do some ecological studies. There's a lot of work to be done, and we just probably need to organize ourselves better. Thank you. Over.
Thank you, Dr. Wayengera, for answering those questions. Before
Can
I
I
come
add
to the
to the
hands,
first question?
Yes, Elizabeth.
Yeah, just to add to the first question, thank you very much, Dr. Misaki, for that response. I just want to add additional information because like from how the person understood it, it's like the second case was really quick. But just to add information, the first case, they boarded the ship on 1st April. That's when the ship left, developed symptoms on 6th April and died on 11th. The second case developed symptoms on 24th April. That is 18 days later. So it was not immediate. So I thought I could add that information on context. And that's why the first case was not tested. You know, when it was first case, probably they couldn't suspect that there could be something to worry about. So he was just being managed. Then he died. That's why he died without being tested, and it became a probable case. But now, when on 24th April, they saw 2 other cases with similar symptoms. That is when now it raised suspicion. And that is what also event-based surveillance is about. And that's when they reported and testing was done. And then hantavirus was diagnosed. Thank you very much.
Thank you, Elizabeth. So Prof. Chirenga, looks like that question has been responded to. I'm not sure if you wanted to add anything.
Just to tell people that a number to take back in their head is that given exposure, symptoms will appear somewhere between 7 and 56 days max. 7 and 56 days, 1 week to 8 weeks. Now, the concept of the inoculum, which you wanted me to bring up, is actually well known, that if the initial pathogen load you get at the time of exposure is high, you are more likely to get severe disease. That has been established. And that's the same principle we use. Although all these public health interventions are not 100%, they could help to reduce the inoculum. And then Mizaki, maybe this one you don't have to explain. Why this logging around? This is quite interesting, but let's listen to other questions.
Okay, food for thought there. So we have some hands online.
Maybe I really want to respond to that question, because when I showed that map of the old world and the new world, you see Africa blank. Tells you that is it really blank, or we need to do some work, especially ecological work, given that the Bunyamwera virus was isolated here in the mosquito, in the Aedes mosquito. Look at some of these potential reservoirs and see what is there. Over.
Thank you. Yeah, and of course, if we have these rats, then you start thinking of things around background immunity, which could probably be because we are not looking for it. I see three hands. One is from Makanga. We will go first, followed by Wilbur, and then Dennis in that order. So, Makanga, keep it short.
Thank you, Winters, and thank you, presenters, for the very precise and elaborate presentation. One of my questions was already answered by my friend Misaki about the mutations, but the other is he opened up a Pandora box that Professor Bruce also mentioned about the animals and the other possible carriers. My question, well, might be probably a nursery question, but let me put it this way. The rats, the rodents, are the ones that have been are the main vectors here. And when we go back to our basic ecology, where these rodents stay is where we find mainly cockroaches. On the other hand, people will bring in cats to kill the rodents. So these two animals or vectors, what could be their role? Because I know we have roaches all over the place, we have cats all over the place, and we definitely have rats all over the place. This is open to any of the presenters.
Okay, we've picked that. I will give you a response. Wilbur, I hope the presenters, you've noted those questions from Makanga. Wilbur, your question or comment?
Thank you. I hope you can hear me. Can you?
Loud and clear.
Great. So my question goes to the last presenter about surveillance and communication. So we know that these days social media is a great source of information. And I'm sure now Ugandans are already picking up messages from social media about this outbreak, which has happened anywhere in the world. So as the Ministry of Health, so your department, how do you stop Ugandans from being unnecessarily worried or believing misinformation that may appear on social media? Thank you.
Thank you, Wilbur. I hope, Hagai, you've got that. Just to let you know, there are people already thinking of the lockdown. We are getting back to the infodemic period. Dennis, keep it short. Dennis?
Thank you, Chair. Can you hear me?
Yes.
Hello? Yes, thank you, and thank you all the presenters. Mine again goes to to the WHR, and again it's riding on Misach's projected maps where we don't have we either don't have data from Africa or we have background immunity. I am curious to know if we can have maybe some kind of racial profiling of these cases of I think they're 6, 15. I would like to know their racial profile. Are they Caucasian? Are they Latino? Are there any Africans in there? Over. Thank you.
All right. Thank you, Dennis. I see 2 more hands have emerged. Allow us to respond to these questions first, and then the second round, which will be short, will be basically for these 2 hands. I see you, Joan and Henry, so I will give you an opportunity to ask in the second round. So the first question was for you, Dr. Wayengera. Things around cockroaches, rats and all that, and they are all Dr. Wayengera.
Thank you, Winters. Winters, there are many questions really, and you know, I like these webinars because you know.
Good evening. Welcome to UMA TV News. I'm your host, and we have the latest updates on the top stories.
Top story tonight. Health officials are issuing an urgent alert following a confirmed outbreak of the Hantavirus in the region. The public is urged to take immediate precautions to prevent further spread.
This rare but serious respiratory disease is causing concern as hospital admissions rise. Authorities are... Good evening. Welcome to UMA TV News. I'm your host, and we have the latest updates on the top stories.
Top story tonight. Health officials are issuing an urgent alert following a confirmed